Okay, good morning, ladies and gentlemen. We are going to start the meeting soon, so please get yourself settled. My name is Dr. Peng Keng Xiang. I'm a urologist here at Mount Elizabeth Novena Hospital in Singapore. I have my two co-moderators with me, Dr. Ukimura and Dr. Kwon. And we are going to get the first session going. And I hope all of you had enjoyed the gala dinner yesterday. As you know, urologists play hard. So we sang very hard last night, but now it's time to work hard. So let's get to this first plenary session going. With me, I'm very honored to introduce Dr. Herbert Lepor. For all the urologists here, you will be very familiar with Campbell Urology, and he's the author of the chapter that's got to do with open radical prostatectomy. So personally, it's an honor to meet him and see the person who wrote that chapter, which I pored over many times during residency years. Anyway, Dr. Lepor was trained in Johns Hopkins Hospital as his resident when he was a resident. And since then, he has gone on to be the chairman of the Department of Urology at NYU, New York University. And today, he's going to share with us his experience from how he moved from radical prostatectomy to focal therapy. Dr. Lepor, please.
So thank you very much, and thank you to Jack and the organizers for the invitation to Singapore. It's been a wonderful visit. I had my tour guide. My daughter was here. So every second that I was awake, she had me running everywhere. So I get to come to the meeting and relax a little bit right now. So again, I'm going to talk about my journey to partial gland ablation of the prostate. So actually that journey began when I was a resident, and my mentor, Patrick Walsh, around the time of my residency, he had the concept that the nerves mediating erectile function were damaged at the time of radical prostatectomy. No one knew the course of the cavernous nerves. He signed me that project, which I diligently, successfully accomplished. And so he included me on the first description of the nerve-sparing radical prostatectomy, the publication in 1982. So since completing residency in 1985, I've performed over 5,000 radical prostatectomies, published fairly extensively of our outcomes. And if we actually look at technical complications, fortunately for me, exceedingly rare, less than 0.5%. When we look at continence, and I define continence as one pad or less, because actually patients will consider themselves continent if they use a small protective pad, and we've published that. And so you differentiate continence from perfect, but it takes time, and continence, in my experience, about 98% with that definition. Preservation of erectile function. Often when we publish our outcomes, we take the person who has perfect erections to begin with, and we look at that cohort in 2 years at 65% are functional, not returned to baseline. And we often don't like to talk about climacturia, penile shortening, or penile curvature. So in about the year 2000, I looked back and I said, well, what are the opportunities to improve the radical prostatectomy, the open? One was to expedite the recovery, improve urinary continence, at least the time to gain continence, improve sexual function, and to decrease local recurrences. And so this is about the time that the robotics came to the market. I know they flew me out to Sunnyvale, and I looked at the robot and I said, you know what? This is really not going to solve any of the limitations of radical prostatectomy. I had the pleasure of debating this topic almost at every continent, but that train has left the station, and the open radical prostatectomy is becoming a lost art. But the question, would focal therapy possibly answer some of the limitations of radical prostatectomy? So if you would have invited me to this meeting in 2010, and that may have been actually the first Euro meeting, because this is Euro 14, I'm still able to do the math despite the jet lag. And I would have suggested that as far as focal therapy and the limitations of radical, that we're not going to improve disease control, that we can minimize incontinence and sexual dysfunction, expedite recovery, but really the next step was we had to know where the location and the extent of what has become known as clinically significant prostate cancer. So I'm going to make the case for focal therapy, and I'm going to have to move through this quickly because of the limitations of time. But here's what I believe, and here's what you need to believe in order to embrace focal therapy. That the aggressiveness of prostate cancer is typically defined by an index tumor. I think we can check that box. That MRI identifies the index cancer in candidates for focal therapy. And this was the first paper that I did that convinced me we were on the right track. I took those men who would have been candidates for focal therapy. I looked at radical prostatectomy specimens. And if you are MRI negative and systematic biopsy negative, contralateral to what we found as an index tumor, it was extraordinarily unlikely that you would miss the detection of clinically significant disease. We learned from the Scandinavian data that majority of men undergoing radical prostatectomy do not have prostate cancer or metastasis-free survival advantage compared to watchful waiting. In fact, you have to do 9 radicals to prevent a mortality and 6 radicals to prevent the development of metastases. The PROTECT trial showed us that low and select cases of intermediate favorable risk disease, that these are appropriate candidates for for active surveillance, and those are the patients that we may not identify prefocal. That the focal therapy reliably destroys the infield prostate cancer, which I'll show you in a moment, and we all know that preserving quality of life is an important outcome for men. So here's sort of the journey. In 2010, actually, Steve Cianti joined our department for a couple years, and he was doing HIFU outside of the US and occasional cryoablation. In 2011, we were one of the first centers in the US to investigate the Sonoblate, and this was for salvage ablation after failed radiation therapy. I have a series of focal laser ablation. We published our 6-month, 2 years, 5 years, and are now getting ready to publish our 10-year data. The problem I really have with focal laser ablation is confluence of energy, because often you have one probe. And if ever you've done cryotherapy, you realize how many times you keep reinserting that probe to get the ideal placement. And you don't really have that opportunity with the current laser technology that we have. In 2016, you gotta love Indy Gill, one of my closest friends. We actually got the first Sonoblate, but he did the first case by 1 day, so we get to say we did the second case at NYU. There's just too much gadgetry for someone as simple as myself. So I started with cryoablation, which is the energy source that I've used, and we've recently purchased the Focal One. So since March of 2017, our first case, Jim Wysock and I have done over 500 cases of primary prostate cryoablation, and every patient was enrolled in a prospective outcomes registry. We had a standardized way of diagnosing cancer, of our treatment planning and our post-treatment surveillance. And again, we would not do focal therapy on a patient with contralateral Gleason Gray Group 1 or distal apical disease, gross extracapsular extension, an MRI. All these men we just exclude. So while there are men with high volume, low risk disease and low volume, high risk disease that we feel are appropriate candidates, we only publish on those men with intermediate risk cancer because we don't want to be accused of operating on patients who should be followed with surveillance, although I feel many of these are appropriate candidates. So again, the first thing we have to do is look at cancer control. So in the first 70 patients, 60 of the patients actually had an infield biopsy. and also a systematic biopsy on the side of the lesions. We biopsied them fairly extensively, and only 2% had an infield residual disease. So we felt that at least at the onset, we were effectively delivering energy to that index lesion. So we've also published our 2 or 3 year experience a year or so ago in the Journal of Urology, and we have extraordinarily high compliance with our mandatory protocol for MRI and biopsy. Actually, at 2 years, 75% have undergone an MRI and biopsy. And at that point, we had 12 recurrences. And again, remember, we're biopsying independent of MRI findings. So 4 of those 12 patients, they had such low volume Gleason pattern 4, they're on surveillance. 2 underwent a radical, 5 were reablated, and 2 we advised to undergo whole gland treatment, and they refused. So this was the data that we published. Our 3-year cancer clinically significant prostate cancer-free survival in-field was 96%. Out of field was 86%. So at the time, the few recurrences that we had were primarily out of field. And freedom from failure, which is they didn't die of the disease, they didn't develop metastases, they didn't go on to whole gland treatment, it was 97%. So we presented our 5-year data at the AUA, and if we looked at clinically significant recurrences at all, it was, and this is in-field, was 86%. If we looked at out-of-field, it's 86%. And freedom from failure is 91%. Now you have to realize in this cohort, the average patient has undergone 3.5 MRIs. The average patient has undergone 2.5 biopsies. And so for the most part, what we have done is because we have demonstrated that if you have no evidence of MR visible disease, we've demonstrated very low rates of recurrence. So now at 6 months, if the MRI is negative, we don't biopsy, but do a mandatory MRI. At 2 years, 3.5 years, and 5 years, we do MRIs. And we have abandoned the obligatory biopsy based upon our published outcomes. So now, at 5 years, we've had 35 recurrences. And again, because we've been doing these mandatory biopsies, we're finding very, very, very low volume Gleason pattern 4. We still call that a clinically significant recurrence. We just say appropriately that they were treated with active surveillance. And you can see those who went on to salvage focal therapy or whole gland therapy, that they had reasonable volume of Gleason pattern 4. Now, a lot of times our colleagues or my colleagues will say, well, look, you have recurrences. That's really terrible. I mean, maybe you should rethink focal therapy. But this is coming from Epstein's paper, which validated the Gleason grade group 1 through 5. And again, if you look at the recurrence at 8 years, if you have Gleason grade group 2, it's about 25%. And if you look at Gleason grade group 3, it's about 40%. Now, I'm not going to necessarily equate a biochemical recurrence with a biopsy identified clinically significant prostate cancer, but even with a radical prostatectomy, you can't simply assume that that's a single treatment, even for Gleason grade group 2 and 3 disease. So looking on to the functional outcomes. So this was the first paper that we wrote. We looked at 6 months follow-up. And this is what's very, very important. Because when we present our quality of life outcomes, you have to stratify it based upon baseline parameters. So for example, if we looked at the improvement in the IPSS, it would only be 2 units. But if we look at those patients who have severe symptoms, severe LUTs greater than 18, you see about an 11-point improvement in LUTs. So in those patients who are bothered by their LUTs, there's a very good chance that will improve after focal therapy, just like it does with a radical. And it's also important when you look at functional outcomes, because actually if you look at functional outcomes, if I were to operate on everybody who had ED, then I say, boy, I cause no harm. That's because you can't make a person who has AD any worse. And so I think it's very important, and we'll show you again when we look at our 2-year data. So we do see some decrease at 6 months, but we do see also a recovery of function over time. Now, this is an important study because what I've stratified the sexual function outcomes based on their baseline function. So on the top plot, you can see men who have really good baseline erections. They have no ED. For the most part, at 2 years, almost all of them have recovered the function, and they're still functional. And the bottom plot looks at those who have ED to begin with. You can't make them any worse. And it's that person who is on the sexual function cliff, the person who comes in who's already on PD5 inhibitors, having challenges with erections. You can't give them the data that you would for somebody who has perfect erections to begin with. I think that's often what we do when we counsel our patients for radical prostatectomy. So this plot is looking at those patients, all patients who were functional, meaning you look at the question 2 on the shim, and if they answer half the time or more that I initiate intercourse, it's successful. So if you take that whole cohort, what you can see is 80% of men will regain function. Now, if you say, let's just look at those patients who come in with no ED to begin with, and we set the bar as being functional, which is half the time you initiate intercourse, it's successful. In that group, it's 96%. But I think it's very important that when you counsel a patient, you do so based upon their function. So the slides that I'm showing are from an old slide deck. So again, if I came here in 2015, here's what I would have said. Here's what I actually was saying at the time when I was speaking on focal therapy, that I was confident the lesion will be successfully ablated. I think we've shown that. I'm confident there are no other clinically significant lesions. I think we've shown that, but we have to be careful because we showed that 20% of the time when we did radical prostatectomies, we had very low volume Gleason pattern 4. If you look at 5 years, we're getting pretty close to the detection of clinically significant out-of-field disease of 20%. So the whole story makes sense, and it's credible if you're credible in what you present. I was uncertain whether clinically significant recurrences of new tumors will develop over life expectancy. I was confident we didn't burn bridges for the future curative intervention, and Jack assigned me talking about salvage radicals, which I'll do in the next presentation. And I was very confident that there was no impact on continence or potency, and I walked that back a little bit on potency, especially in the patient that has some ED to begin with. So where am I in 2024? It's an outpatient procedure with expedited recovery. In over 500 patients, we only admitted one patient. That was with AFib in an 82-year-old man who had Gleason grade group 4. We've never had incontinence. We've never had rectal injury. And you actually will improve LUTs if they have baseline LUTs. That there's significant reduction in semen volume. You better tell that to patients. For some patients, as long as they know that ahead of time, then it isn't that problematic. As I said, men with moderate ED at baseline have the greatest potential impact on sexual function. That 90% no whole gland treatment in 5 years, and we move on to whole gland treatment if we think it's appropriate. In and out of field recurrences, about 25%, and often managed with active surveillance or focal therapy. And so what we do now is our protocol is to do a 6-month MRI and to do one at 2 years, 3.5 years, and 5 years. And we only biopsy, and we have data to validate this if in fact there's no MRI new findings. Now, we will find clinically significant cancer in MRI invisible disease, but that's often very, very, very low volume. So I have no vested interest in whether someone decides to do a radical or focal therapy. I just show them my data for both. I provide an evidence-based approach emphasizing a shared decision model. I will tell you, if you do that, and for those of you who only do radicals and are sort of putting focal therapy sort of in the distant future, rethink that. Because 2/3 of my patients will end up doing a focal therapy who are candidates for focal therapy if I give them the option. And again, I have no vested interest. I'm happy to continue to do radicals. What drives the decision? It's the avoidance of incontinence as far as the radical, and the avoidance of ADT with radiation therapy. You start telling them, that they're going to have 6 months to a year and a half of the consequences of ADT. That's not inconsequential. Improve sexual function, and the opportunity for salvage treatment, which we'll discuss in the next session. And so are we making the right decision? I think if I were to redo the slide when I get back to the States, I'm going to take out some of those question marks. I think that this is a very reasonable treatment. It's just building appropriate expectations. And with every treatment, we need surveillance. You need that with a radical, you need it with radiation, and even more importantly, you need it for focal therapy. So again, thank you very much for inviting me to your beautiful country. I've thoroughly enjoyed meeting the people and seeing probably most of the sites due to my tour guide, and thank you for the invitation.
So I think we are a bit over time, but in view of Dr. Lepor's rare visit to Singapore and being such a luminary, we'll entertain 1 or 2 questions for Dr. Lepor, if there's any.
So I just like to ask the question, for those who only do, who haven't yet started offering focal therapy, of those who treat prostate cancer, just a show of hands, how many have yet to embrace focal therapy? And don't be embarrassed, because if I ask that in the States, the whole audience raises their hand. Yeah, and I would say the only thing that I would also say is when we write, when Jim and I do focal therapy, let me tell you something. We can have like a centimeter lesion, and we'll put 4 or 5 probes in. I mean, we're cancer surgeons. So we're not just putting 1 probe, 2 probes. If it's sort of coming to the midline, we'll cross over the midline, because there's really little harm in having some of that medial disease that you treat. So, we're a bit careful. And what I say is that, you don't have to do obligatory biopsies, but here's what I would tell you. As you embark on your experience, you do need to do biopsies to show that you actually have oncologic control, so that you can avoid them. So when we say you don't have to do the biopsies, it sort of it determines how aggressive you are in your focal therapy.
If I may, Dr. Lepor, congratulations on your excellent talk and your excellent outcomes on focal cryotherapy. I learned so much on how you treat extensively with greater margins, and always remembering that we are cancer surgeons. So I'm going to ask you a question I asked the group yesterday as well. How far do you push the boundaries of Gleason pattern 4? Would you treat slightly higher volume 4+3? Would you treat small volume 4+4, or do you exclude them?
So great question. And, that's the art of medicine. Look, there are many times that just in seeing the patient with localized disease, that active surveillance is too little and a radical prostatectomy is too much. And you sort of know that when you're sitting with that patient. So if I have a significant anterior tumor and I biopsy that, and it's a 76, 78-year-old healthy man, right? And that is a Gleason grade group 4. I think a radical I think a focal ablation is a very reasonable option for that patient that probably has potential consequences over their lifetime, mainly developing metastases, not probably dying of their disease. And so I think that would be the appropriate candidate. I think there's times when it's just wrong to do focal therapy. I always tell our residents that just because the patient wants it is not the reason to do it. But, they do make their own decisions. And I've had a couple patients who I have discouraged focal therapy those who I think it's not inappropriate, but I've just discouraged it, and 5 years later, they're doing well. And I think the other thing is, you know, I run a meeting, and I've kept trying to get Egner to say that sometimes Gleason Gray Group 1 is real disease. So I make it a 2-centimeter lesion. He still says that's not disease. And then I tell him that he's BRCA positive, and I still can't get him to say that Gleason Gray Group 1 is significant disease. But you know, there are many times that Gleason Gray Group 1, you just don't feel comfortable with surveillance, and I think the ablation can actually eradicate the disease, and you basically have surveillance without their cancer.
Excellent. Herbert, congratulate about your data. A majority of the salvage treatment patient select the focal therapy again. My question is, what's the difference between the salvage as radical versus repeat focal? What's the difference of these populations?
So, and I will tell you, a couple of the patients in our early series that had significant apical disease, those are recurrences that I would not do focal therapy in retrospect. And so if we have significant recurrence that I think is still manageable, right, where the disease is where there's a reasonable chance that I can ablate it, I have no problem with a second ablation. Here's what I'll generally, and I know we have a whole session on this, but I will tell a patient is that if I do a salvage ablation, I will never do a radical on you afterwards. So that's your one chance to go do a radical is after your first salvage, because after the second salvage, then you're like a salvage after radiation. But I would generally say, and I think the other thing is, you know, we know from the Scandinavian data that many patients would do well if untreated. And I think if you actually, let's say at 6 months you see no disease, and let's say at 2 years you have significant disease, I think that's defining an aggressive cancer that you probably better address with whole gland treatment.
Thank you. Actually, I have more questions, but because of the shortage of the time, we'd better to close this session, and I'll ask you in the flow. Okay? Thank you very much.
Thank you.